Now coming to one of the questions that had been asked for the NEET exams. All of the following techniques are used to control bleeding from bone during mastoid surgery except using a bone wax. Will it help? Yes, bone wax are collected while during a mastoid surgery, and that helps in sealing the blood vessels that have been damaged. Now what about bipolar cautery? Of course, bipolar cautery can help in controlling the bleeding. And diamond drill over the bleeding area, will it help? Yes. How? By using diamond drill, the bone dust will go directly into the blood vessels that are causing the bleed, and it gets sealed. And will the use of cutting drill over the bleeding area help? No, that won't help. So the answer to this question is use of cutting drill over the bleeding area. Now what is the next complication that you have to know? Next complication is petrositis, the inflammation of the petrous part of the temporal bone. Okay, the deeper part of the temporal bone is what is known as the petrous part, because it is a hard area when compared to the squamous part. And in this petrous part, in 30% of the patients, it is pneumatized. So in these patients, there is high chance of mastoiditis to go and become petrositis, okay, by the spread. Now how is it occurring? It is similar, just like how I told about the mastoiditis. Okay, that is, you have got the, this is the posterior wall. Okay, now you have the otitis here, and you have the mastoid aerosol system here, right? And from the mastoid aerosol system extends the petrous aerosol system and goes into the apex, right? Now here also you have aerosols in 30% of the patients, just like the mastoid aerosols that you see here. Okay, now what is happening here? In these petrous aerosols, first of all it will undergo inflammation. Okay, there will be hyperemia and inflammation. Okay, and after inflammation occurs, what happens? There will be exudation occurring because of the inflammatory materials going and spreading, and that can result in pus formation. Okay, so pus formation can occur next, and this pus can fill the aerosol system, and because of the pus and the hyperemia, it can result in hyperemic decalcification, and finally it can also become a single cavity, just like I told about coalescent mastoiditis. And this inflammation of the petrous part of the temporal bone is what is known as petrositis, and this petrositis is associated with a syndrome. What is that syndrome known as? This is what is called as Gredinego syndrome. What is this Gredinego syndrome? What are the important relationships of petrous apex cells? Near here you have got the sixth cranial nerve as well as the trigeminal ganglion, which is seen within the Meckel's cave. Okay, it is seen within the Meckel's cave. You have the trigeminal ganglion. Okay, so if it spreads into the petrous apex cells, this is the petrous apex area. Okay, near to that you have the sixth cranial nerve as well as the fifth cranial nerve ganglion or the trigeminal ganglion within the Meckel's cave, and what that can result is the Gredinego syndrome. And this Gredinego syndrome is characterized by 3 Ds. What are these 3 Ds? The first D is diplopia. Why is this diplopia occurring? Because abducent nerve is supplying the lateral rectus muscle. So what happens when the lateral rectus is paralyzed? The patient will not be able to abduct the eye. Okay, so when you are looking to one side, one eye will remain in the center, whereas the other eye will move laterally. Okay, so because of that, what happens? There will be double vision. Okay, that is what is known as diplopia. Okay, so that is due to the Sixth, nerve palsy. Now, what about the trigeminal ganglion involvement? When the trigeminal ganglion is involved, what happens is there is deep-seated retroauricular pain. Along with this, there is facial paresthesia as well. Okay. So, this is another feature that is occurring in Gradinikov syndrome, and finally you can have ear discharge. Okay, so these are the 3 Ds: diplopia, deep-seated ear pain, and ear discharge. Okay, so that is about the complication of petrositis. Now, what is the next complication that can occur? What else do we have here? When you look carefully, you can see that there is one canal which is projecting into the middle ear. What is that? That is the lateral semicircular canal. Now, what happens when lateral semicircular canal is involved? That can result in a condition which is known as labyrinthitis. Now, this labyrinthitis can be divided into 2: diffuse and circumscribed. Now, the diffuse can be further divided as diffuse serous and diffuse purulent, and the circumscribed labyrinthitis is what is known as lateral semicircular canal fistula. Okay, so in the labyrinthitis, it can be a diffuse serous or diffuse purulent. What is this diffuse serous? When the whole of the labyrinth is involved by the inflammation, initially the patient will be having vertigo, vomiting, nausea, everything will be present, but it will be transient and temporary because it is only serous fluid in that. But later on it becomes purulent, filled with pus, and what happens finally, there will be a dead labyrinth because of that. And so what happens is there will be a nystagmus to the patient, and this nystagmus will be to the opposite side in case of a purulent labyrinthitis, whereas in serous labyrinthitis it is to the same side. Okay, so serous for same and P for opposite. Okay, so that is what is happening when the labyrinth is getting involved. You can have vertigo. Along with the vertigo, there will be nystagmus, and this nystagmus will be towards the same side in case of serous labyrinthitis, whereas it is to the opposite side in case of a purulent labyrinthitis. And when the patients the symptoms are subsided, even then when you are looking at pure tone audiogram, because the purulent labyrinthitis will result in dead ear, there will be SNHL. Okay, whereas in case of serous labyrinthitis, the SNHL will be transient, it will recover later on, okay, with the recovery of the vertigo. So that's about labyrinthitis. Now coming to the next complication, intratemporal complication, that is the facial palsy. Okay, now why does this facial palsy occur? We know that the facial nerve is occurring in the medial part of the middle ear. In the medial part of the middle ear, the facial nerve is seen just below the lateral semicircular canal projection, and that can result in its involvement. And in acute otitis media, when it occurs, you have to suspect a case of dehiscent facial canal. Okay, dehiscent facial canal should be look for when it is an acute otitis media and the patient is having a facial palsy. Okay, whereas in chronic otitis media commercial disease, because of the bone erosion of the fallopian canal itself, there can be facial palsy. That is another case. But here, when a patient is having acute otitis media and then he is having facial palsy, that means there is a dehiscent facial canal. Okay, now facial paralysis is more common in chronic otitis media commercial disease, I already told you. And in mucosal disease, the chance of involvement is very less. But there is one entity called as tuberculous otitis media. It is especially seen in people with primary tube B when you have in tuberculous otitis media, what do you see? You will be having pale granulation tissue, profound hearing loss, profound SNSL may be present, and then what else do you have here? You can have facial palsy and multiple perforation may be present, multiple small pinpoint perforation, but later on it can coalesce to form one single perforation. Okay, so that is the thing you have to know about tuberculous otitis media. In that case, you will have pale granulation tissue, then there will be painless discharge present, painless discharge, and there will be profound SNHL, and there will be multiple perforation. Okay, so these are the things that you have to know about a tuberculous otitis media. Now, what are the other complications you have to know? There are some intracranial complications, right, that you have to learn in case of otitis media. What are they? The intracranial complications can be easily remembered if you just remember this. That is, you have the mid layer here. So this is the mastoid cavity here. Here you have the external aortic canal, right? So this is the dural plate, this is the sigmoid plate, and above the dura you have various layers. Okay, what are they? You have the, if this is the dura, here you have the subdural layer, and this is the subarachnoid space. So this is a periosteum. Okay, now you have the sigmoid sinus over here, so that is why this is called as a sigmoid plate. Okay, so you have the dura here, arachnoid here, and yes, you have the pia mater also here. This is the dura. Okay, this is the arachnoid and this is the pia mater. This is the brain that you have here, brain. Okay, so if this is the dura, this is the subdural space you have here. Here you have the subarachnoid space. Okay, and then this is the brain. Okay, so what are the various complications that can occur? What are the various intracranial complications? Okay, we have already learned about the various intratemporal complications. Now, what are the intracranial complications? Either it can directly go into the subarachnoid space, which results in the most common complication. What is that? What is the most common complication? That is the meningitis. That is one thing that can occur. Now, what else can occur? It can come from here. That is, if this is the dura, between the dura pus can collect, between the dura and the periosteum pus can collect, and that can result in extradural abscess. And within the dura, when it gets collected, that is what is known as subdural abscess. Now, if the infection directly is seen within the brain, that is what is called as the brain abscess. Okay, so these are the various complications that you have to remember, and along with that, when the complications spread into the sigmoid sinus, it can result in sigmoid sinus thrombophlebitis. Okay, sigmoid sinus thrombophlebitis can occur, and when this thrombophlebitis goes on to spread into the confluence of sinuses, that can result in increased intracranial tension, and that is what is called as the otitic hydrocephalus. Okay, so these are the various complications. You can have a cerebral abscess, or you can have a subdural abscess, extradural abscess, lateral sinus thrombosis. Okay, now these are the intracranial complications. Now what are the intratemporal complications? Intratemporal include labyrinthitis, facial paralysis, coalescent mastoiditis, and petrositis. Okay, the intracranial complications can be further divided in another manner, that is the septic complications, which are the meningitis and the various intracranial abscesses, that is extradural abscess, subdural abscess, and the otogenic brain abscess, and the other complications, that is due to the spread of thrombus and the thrombophlebitis, that is the lateral sinus thrombophlebitis and the otitic hydrocephalus. Okay, now coming to the most common intracranial complication, what is that? Meningitis. How will you look for a meningitis in a patient with chronic otitis media? You will have to check for neck rigidity, and you will have to look for the Koenig's sign and Brudzinski sign if it is present or not. Okay, so the patient will be having fever, neck stiffness. Okay, and in that case you will have to check for these signs in a patient having ear discharge. Okay, now what else can cause fever and headache in a patient with ear discharge? It could be an extradural abscess, okay, where the pus collects like this, okay, outside the dura. When the pus collects, that is what is called as the extradural abscess, or the pus can collect within the dura, then that is known as the subdural abscess. Okay, then the picture will be like this. It is what is called as the subdural abscess. Okay, now what else can happen? You can have the abscess spreading, right, and where else it can go? It can go to form the otogenic brain abscess. What are the two areas where an otogenic brain abscess can occur? One thing, it can occur in the temporal lobe of the brain, of course. The other area is the cerebellum. Okay, so these are the two areas where an otogenic brain abscess can occur. Okay, so otogenic brain abscess can be of two types. One is the temporal lobe abscess and a cerebellar abscess. Now, how will the temporal lobe abscess be seen when you take an imaging, whether it is MRI or CT? You can see a ring enhancing lesion. Okay, a ring enhancing lesion is typically seen in a case of abscess. Okay, now what are the various stages of abscess formation? Initially there will be stage of encephalitis, then stage of localization, then enlargement, and finally the rupture of the abscess can occur. Now it can be further divided as various stages like this, that is stage of early cerebritis, stage of late cerebritis, early capsule formation, and finally late capsule formation. Okay, so these are the various stages of brain abscess. Okay, stages of brain abscess. Now, how will you understand if the patient is having a cerebellar abscess or a temporal lobe abscess? What are the clinical symptoms and signs? The patient will be coming in the drunkard gait, and there will be typical nystagmus. It could be a pendular nystagmus, as in a case of a central nystagmus. Okay, or it could be a rebound phenomenon that you can elicit, or the typical dysdiadochokinase or coccinaceae. Okay, and the finger nose test. This is the dysdiadochoccinaceae that you see here. Here you can see the finger nose test. When you do, the patient will be having incoordination, and this is the rebound phenomenon. Okay, rebound phenomenon. All these things you have to check for. Okay, this is dysdiadochoccinaceae. Only when you see a patient having fever with neck stiffness with vomiting, you will be thinking about meningitis, but the cerebral abscess and the cerebellar abscess part you should not forget, and especially if the patient is having a drunkard's gait and a central nystagmus, then you should not forget it at all. Okay, and the temporal lobe and the cerebellum, these are very closely related to the ear. That is why these are the areas where you will have the abscess formation. Okay, the spread of the temporal the spread of the infection from the temporal bone will occur to the temporal lobe as well as the cerebellum. Now, how does the temporal lobe abscess present? You know, frontal abscess present with personality changes, right? Whereas the temporal lobe abscess presents with nominal aphasia along with the seizure attacks. Okay, nominal aphasia, seizure attacks. These are the features of a temporal lobe abscess. Along with that, there is a particular thing. What is that? That is the pie in the sky appearance. What is the pie in the sky appearance? It is the superior chondranopia that is seen in case of temporal lobe abscess. Okay, superior chondranopia. It is a homonymous chondranopia. Okay, homonymous. And why does this occur? It occurs because of the fibers that are passing to the temporal lobe are actually supplying this area of the visual field. Okay, so there is homonymous chondranopia occurring. Superior homonymous chondranopia occurs in temporal lobe abscess along with seizure attacks and nominal aphasia. Okay, so this is the reason why the superior chondranopia is occurring, and when there is an abscess you will have to drain it. Okay, the abscess has to be drained. How will you drain the abscess? For that you will have to go for a craniotomy. So a neurosurgery consultation has to be sought. Okay, neurosurgery consultation and abscess drainage by craniotomy, and only after that you will go for MRM to remove the infection from the mastoid. Okay, so initially you will go for craniotomy and followed by you will go for MRM in a second sitting after the patient stabilizes. Okay, now what is the other complication that can occur? I told you there is a spread of infection to the nearby area. What is that? You can see the sigmoid sinus here, right? This is the sigmoid sinus, and when there is inflammation here, what is happening? There is initially a perisinus abscess formation, that is outside the wall of the sinus there is abscess formation, and later it spreads into the walls. Okay, so initially the outer wall is involved and finally the inner wall is involved, and this leads to thrombus formation within the sigmoid sinus. Okay, so within you have the thrombus getting formed here. Okay, so this is how a thrombus is formed, and this is what is called as the mural thrombus, and this thrombus along with the inflammation can spread. Okay, so that is what is known as the sigmoid sinus thrombophlebitis. Now, how does this spread occur? It can either spread downwards into the internal jugular vein, or it can go upwards into the superior sagittal sinus, as you can see here. And when it goes into the superior sagittal sinus and blocks the confluences sinuses, that is what results in the otitic hydrocephalus. Okay, otitic hydrocephalus. When it goes into the internal jugular vein, it results in cord-like tender IJV in the neck. Okay, that results in severe neck pain. Okay, so this is the inflammation of outer dural wall going to form the mural thrombus, and later there is abscess formation, and this can result in propagation of the thrombus. Okay, and when this thrombus that is seen within the sigmoid sinus, when it is laid down as emboli, what happens? These emboli results in spikes of fever. Okay, these spikes of fever is what is known as picket fence type of fever. Okay, picket fence type of fever. So when you are plotting the temperature chart, you will get a pattern like this, similar to that of a picket fence. That is why you get the name picket fence type of fever that is seen in sigmoid sinus thrombophlebitis. Okay, sigmoid sinus along with the transverse sinus is what is known as the lateral sinus, and so inevitably the lateral sinus also get involved. So that is how it gets the name lateral sinus thrombophlebitis. Okay, so I told you the thrombus can spread into the IJV as well as it can go into the superior sinus. You have a mastoid emissary vein here. It can get blocked because of the thrombus, and when it gets blocked, what happens? There will be a pitting edema in the mastoid emissary vein area. Okay, and that is what is known as the Greisinger's sign. Okay, Greisinger's sign is pitting edema in the area drained by the mastoid emissary vein. Now, what else have you got to look for? I told you the IJV is getting occluded, right? So when you are compressing the opposite IJV, what will happen? There will be increasing CSF pressure, right? That you can look for by using a manometer. Another thing that you can look for is the Crowley-Beck sign, where the retinal engorgement can be observed with the help of a ophthalmoscope. Okay, when you are compressing over the opposite IJV, there will be increased CSF pressure, and when you use a fundoscope, you will be able to see retinal vein engorgement, and that is what is known as the Crowley-Beck sign. Okay, and this is the Tauber air test or the Kuchenstedt test, where you are looking for increased CSF pressure when you are compressing on the opposite IJV. So what are the things that you look for? One thing, you have to look for a Greisinger's sign, that is the pitting edema of the mastoid emissary veins draining area of the mastoid. Another thing, you have to look for Crowley-Beck test. In Crowley-Beck test, what you are looking for? You are looking for retinal vein engorgement. Okay, retinal vein engorgement. And finally, you will be looking for the Kuchenstedt test with the help of a manometer. Kuchenstedt test, or it is also known as the Tauber air test. Okay, for confirmation, you will be doing a CT with contrast, where you will be seeing that there is no contrast uptake in the area of sigmoid sinus, and that is what is known as the empty triangle sign or the delta sign. Okay, empty triangle sign or the delta sign. So this is how you look up for a patient who is suspected to have a sigmoid sinus thrombophlebitis. Now, when a patient comes to you with sigmoid sinus thrombophlebitis, you will have to admit the patient, do a CT for confirmation of the diagnosis, and then what will you do? You will give IV antibiotics. Along with that, you will have to go for a modified radical mastectomy, and then you will have to explore the sigmoid sinus. Okay, and then you will have to occlude the vessels where there is a thrombus. Okay, that will need ligation. That part of the sigmoid sinus will need ligation after removal of the thrombus. Okay, nowadays only modified radical mastectomy is being done because of the superior quality of the IV antibiotics. Earlier on, the pre-antibiotic era, the whole of the thrombus used to be removed until there is no more thrombus is available, and then ligation used to be done. But nowadays that is no longer done. Only modified radical mastectomy will be needed for the procedure. But you will have to know the whole thing about the sigmoid sinus thrombophlebitis, the presentation, the type of fever, okay, the recurrent bouts of fever. Why is it occurring? It is due to the formation of the embolus, and these embolus will result in the bouts of fever. And along with that, another thing that can occur is hemolytic anemia. Okay, when you do a peripheral smear, you will be able to see hemolytic anemia. Why this is occurring? The hemolytic anemia is occurring because the vessels have been damaged, and when the RBCs go through the thrombosed blood vessels, what happens? These RBCs undergo lysis, and that can result in hemolytic anemia. So this is one thing that you have to look for in a patient with sigmoid sinus thrombophlebitis. Okay, so that is about sigmoid sinus thrombophlebitis. Now, what happens when this sigmoid sinus thrombophlebitis goes on to spread into the superior sagittal sinus? It can result in blockage of arachnoid villi, and that can further result in decreased CSF absorption, and this results in raised CSF pressure, and this is what is known as the otitic hydrocephalus. Otitic hydrocephalus. It is also known as Simmons syndrome. Okay, Simmons syndrome. The great Andrew Simmons departed recently, right? Simmons syndrome. And here, when you are checking with the manometer, you will be able to see that the CSF pressure is normal. So this is a cause for normal pressure hydrocephalus or a pseudotumor cerebri. Okay, pseudotumor cerebri. So this is the next complication of otitis media, that is otitic hydrocephalus, and it is occurring due to the spread of the thrombus from the sigmoid sinus into the superior sagittal sinus, resulting in blockage of the arachnoid villi, and due to this there is decreased CSF absorption, and that is resulting in hydrocephalus. Okay, so another question, true about safe CSOM. Etiology is multibacterial, oral antibiotics are not effective, otitic hydrocephalus is a common complication, ossicular erosion is not seen, eardrops have no role. Answer is etiology is multiple bacteria. Okay, rest all are false. Now, treatment of brain fungus in mastoid cavity. What is this brain fungus? This is another complication that is seen following a CSOM, but it is not much discussed in the undergraduate textbooks. That's why I included this question. Brain fungus is actually the herniation of the brain into the mastoid cavity that is happening because of the erosion of the tegment ball. Okay, brain fungus is the herniation of brain into mastoid cavity, and it has got nothing to do with fungi. Okay, and nothing to do with fungus. So in this case, what is the treatment? You will have to go for a surgical repair, not amphotericin therapy, not miconazole powder application or syringing. You are getting confused because of the fungus in it, right? So brain fungus is actually herniation of brain into mastoid cavity, and it is a complication of chronic otitis media, and in this case there is no relationship with a fungal infection, and the only thing that you can go for is a surgical repair of the area. Okay, so that there is no more further herniation occurring. Okay, so today we have learned in detail about the various intratemporal as well as intracranial complications. What are the intratemporal complications? This is a question that can be asked as an essay. It can be asked even as an essay for postgraduates as well. Okay, so such an important topic. Okay, now intratemporal complications, easy to remember, mastoiditis. From there it can spread to form the various post-auricular abscesses. Yes, what else can happen? You can have labyrinthitis, facial nerve palsy, Petrositis. Now coming to the intracranial complications, what are they? There could be subdural abscess, extradural abscess, brain abscess in the form of temporal lobe abscess or a cerebellar abscess, meningitis, sigmoid sinus thrombophlebitis or lateral sinus thrombophlebitis, okay, and otitic hydrocephalus. And apart from all these, there is one other complication which is also an intracranial complication. What is that? Brain fungus. It is not much discussed, but you will have to know about this complications. Okay, now you have learned in detail about chronic otitis media and also about the various complications associated with not just chronic otitis media but also with acute otitis media, right? If you have any doubt, you can mail me and ask me. Please go and read today, sir. This is a very important topic, not just from the undergraduate point of view but also from the postgraduate point of view, and a lot of MCQs may be asked from this area. Okay, so please go and read today itself and also revise the topics that you have already learned. Thank you.